I keep catching myself. I'm so not good with this. I'm like,
oh yeah, like, hey. I'm kind of looking at you. I'm like, can I see? I can't really see her.
I know.
She's over there. Okay.
Welcome to Balls Deep, a humorous yet informative medical show with a mission of optimizing your performance in the bedroom, the bathroom, and the boardroom. I'm your host, Dr. Joe Pizzona, a board-certified urologist and CEO of Pizzona MD. We hope you enjoy. Now, let's jump right in.
Hi, Stream Team. It's me, Kat Williams, and I am solo for episode 2 with Dr. Brooke Faught, talking about female sexual dysfunction. And we're just going to dive right in. Let's go deep.
Balls deep.
Okay. Dr. Pizzona still on vacation, and I'm taking over the podcast with Dr. Brooke Faught, our doctor of nursing practice.
are we saying vacation? Is that what we're saying?
We're saying vacation, but actually what we've done is we threw him out.
Oh, yeah.
Yeah, because this is a female discussion, and I think we're better to take that over than Dr. Pizzona, right?
No
I think
boys.
I'm right.
Yeah.
No boys allowed. No boys allowed. So, Brooke, this is our second episode. We have been talking about Hypoactive Sexual Desire Disorder, HSDD.
Very good.
And now we are going to talk about, we'll reiterate what that is, but what are the treatments? What are our options if this is something we're dealing with?
Yeah.
So first, hit us up one more time with what is this?
Yeah.
The difference between low libido, you know, you'd rather be watching Netflix and not really interested in sex, or you're not really interested in sex and it is more of a disorder.
So HSDD, Hypoactive Sexual Desire Disorder, is the condition, whereas low libido, the symptom, just the lack of interest in sex. You can have a symptom, but it doesn't constitute a full condition. Okay. The condition is what we're talking about today. The condition is what warrants potential treatment. That's what brings people to me. They're bothered by a symptom that leads to a potential condition, that leads to a potential treatment. So now we're going to talk about what are the potential treatment options. And as a healthcare provider, I sometimes refer out for sex therapy. I sometimes prescribe medications. I sometimes recommend supplements. I sometimes get creative and I do a multitude of different things, and I'll recommend, various, sometimes even physical therapy if I find that people are really tense and stressed, or they have, pelvic floor issues and weakness, and maybe they're not becoming aroused and achieving orgasm, and that's making them distressed where they're not enjoying sex, so that's leading them to not be motivated to want to have sex. It's this domino effect.
So it's kind of a deeply layered thing. It might be more than one issue. It might be stress. It might be also HSDD. It might be all these things working together against you.
Yes.
Okay.
So now you can see in a very quick, a very short conversation how this can be so complicated. It's not like men with, a penis doesn't work. You give them Viagra and off they go, which I'm being kind of silly. It's not always that simple. But it takes a conversation. It's not as simple as you just go online and Google, what can I do about libido? Oftentimes there's a lot of different things that can cause distressing low sex drive. So you really need to find a trained, educated healthcare provider that's familiar with sex medicine that you can talk to openly and feel comfortable with to have this conversation to determine what is the best course of action.
Okay. So one thing that I learned recently, and I think this is going to be news to a lot of women, there are treatments. And I mean treatments as in medication for this HSDD, low libido issue. I've never heard of this. What are these medications? How long have they been out there? And why have we never heard of these?
Yeah. Well, Flibanserin, or Addyi, was the first medication to reach FDA approval. That was back in 2015, if you can believe that.
Okay, that's almost 10 years ago, Brooke.
Isn't that insane?
And I've never heard this name. I've never seen a television commercial, an ad in our fashion magazines. I've never heard of it.
Yeah.
10 years.
There have been laws prohibiting marketing of this particular medication.
Laws? Why?
Yeah. There's a lot of different reasons. That would be our next
Okay,
podcast.
that's a different podcast, but wow, never heard.
Yeah.
Okay.
And that's kind of what I was referencing in our last podcast, that there's a big discrepancy with how we even just the beginning stages of research between kind of some of these male-oriented and female-oriented medications and products, how we get to the point of seeking FDA approval, and then even when we get to the point of marketing some of these products. So the length of time it takes to bring a product to market, and then again, the process to actually make individuals aware. Whereas when we go back and we do a comparative analysis looking at things like Viagra, which everybody's familiar with Viagra.
Oh, everybody's familiar with Viagra. It's everywhere, and it was everywhere within, 12 seconds.
Yeah. And now I think they pay us to like take it. I mean, I think when you get your prescription, there's like a bag of money with it,
Okay. Wow.
Just kidding. There's not really, but
almost.
It's very, very accessible. It's in your face. Everybody knows about it, And when we look, it's ironic when we look at the risk factors associated with some of these medications that are so highly marketed and so accessible, it's laughable almost how unbalanced the risk factors are. I mean, there's in my opinion, the risk factors are much higher for things like Viagra and some of these other medications compared to things like Addyi, which is flibanserin. That's a generic name of it. So Addyi, going back to that, this is
Addyi. Spell this.
Addyi.
Addyi. Addyi. Google this, everybody.
Add your interest.
Is that what it is? Was that from the marketing team, or is that how they named the drug?
That's what I was told. I've never verified that.
Add your interest.
Yeah.
Okay, well, it's helpful to remember that.
Yeah.
But that's the drug.
It's a little pink pill. It's one pill that's taken every night at bedtime.
Okay.
It's a 5-HT1A receptor agonist and 5-HT2 receptor antagonist. And I know you're going to remember that.
No idea.
Would you please repeat that back to me,
Absolutely,
Kat?
I cannot. I'm glad you know it and you are a medical professional, but I'm just going to remember the pink pill.
There you go. It's a little pink pill. And so it was called the female Viagra, but it's really important to understand it does not work like Viagra at all. So yes, it is a pill for sexual health, but it works on the central nervous system instead of the blood flow system, the way that Viagra works.
Okay.
So it works on the brain. As I was saying when I was talking about the receptors, it works on the brain kind of similarly to how medications work for like depression and anxiety. They work on the central nervous system, but an entirely different mechanism overall. So when we think about libido in some individuals, there's a theoretical imbalance in serotonin, dopamine, norepinephrine, that sort of thing. And this is, in a shortened form, this is somewhat balancing that out. And it can take up to 8 weeks, maybe a little bit more, for things to somewhat balance out if this is going to work for them.
Okay, so you would have to take it for at least 8 weeks before you potentially see any benefits. It's not something you're going to take like a Viagra where you take it and you see some kind of a result very quickly.
That's the other big difference with it. You have to. It's a game of patience. You have to take it for a bit of time before it's going to kick in. If it does work, it usually is a really profound effect. So a lot of individuals will say that it's almost like overnight. They're like, holy cow, I woke up and all of a sudden I'm having these dreams and I'm like, does anybody, do they notice what I'm experiencing?
Okay.
But it's a really, really noticeable effect.
I mean, is it one of these things, I'm just going to get a little nasty here, is it one of these things where it's all of a sudden, like you remember your high school boyfriend and everything was very exciting and now you're married and it's like, it's nice, but it's not like that teenage excitement anymore. Does it take you back to something like that?
I'm glad you brought that up because it doesn't change personality. So I like to emphasize to patients because some patients are really worried. They're like, oh my God, am I going to turn into some like crazy, like crazed sex fiend where I'm going to run down the street
nymphomaniac.
naked?
You're just going to rip your clothes off and get on a bus.
Exactly.
No, you're not going to do that.
Exactly.
Okay.
Yeah. However, if that is your personality,
if that's who you were already, we can't help you, but okay.
Exactly. But if that's, like, for instance, if you tell me that, before you got married or early on in your relationship, that's where you were and that's kind of what you miss, there's a potential that this could help to restore that if it's due to that imbalance. So that's kind of what we're looking for. That's kind of your baseline. Mm-hmm. And then we kind of look for that and we kind of wait it out. And there may be other factors too. So sometimes we'll use the Addyi and then we'll maybe add in sex therapy or maybe we'll add in some testosterone or some other therapies as well. So it's not always just by itself, but We'll start with that in some cases, give it that solid 8 weeks, see how you do. And then I'll bring patients back in like 8 to 12 weeks and we'll reevaluate and see how things are going.
Is it something, so let's say you've taken Addie, you've given it a shot for the 8 weeks. Is there anyone it doesn't work for? Yeah. Okay.
It's kind of a 50-50. So it seems to work in about half of patients that it works for. And like I said, when it works really well. And when it doesn't work, it usually doesn't do much of anything. And that's usually the worst kind of outcome. So the side effect profile for most patients, it's a really, in my opinion, clean side effect profile. Biggest side effect is sleepiness. So ironically, a lot of my patients tend to really like that. They'll dose it at bedtime. And so they'll sleep really well.
That's not terrible.
It's not terrible, and it does not cause weight gain. And in fact, some individuals lost weight during the clinical trials too. So you sleep well, you could potentially lose some weight on it. Again, it's not indicated for sleep or weight loss, so I like to emphasize that. But it doesn't cause weight gain. That's a big one that people always want to know about. But other than that, I mean, it really tends to be tolerated very, very well. You have to be cautious, of course, with any medication, making sure that you're not allergic to any of to the product or that there's no contraindication with other medications. And sometimes you want to talk to your pharmacist and obviously your prescriber with it. But, in general, it's worth a shot, worth a conversation if this is something that's bothersome for you.
Wow. And you have been prescribing this for how long?
The entire time it's been out.
So that's almost 10 years. And I mean, Brooke, in your opinion, like what's a percentage of women this works for? You said kind of 50-50?
Yeah, I would say I'm pretty, I can tell pretty well who's going to be a good candidate. So I would say I have slightly higher rates of success with it simply because I'm pretty savvy with using this medicine. But I would say in general, it is a 50-50 type of medication. I do tend to overlap a lot. Now, again, in the clinical trials, it was used independent of other medications and supplements. But I do find that regardless of what you're using to treat for HSDD, you're going to get your best outcomes if you use a biopsychosocial kind of approach. So when you look at the relationship, when you look at, the chemistry, when you look at just every facet and factor that could play a role in their distressing low libido, you're going to get your best outcomes, obviously.
Okay. So this is really curious to me. Is Addie this one particular, because it's only this one drug, right? This is the only one for women low libido. It's not like
one more.
There's one more.
Yeah.
Are you kidding? Okay.
This is the only pill. So you are correct that this is the only oral pill, but there is an injectable medicine that can also be used for low libido as well.
Okay. Also, second thing I've never heard of. There's an what is this one?
So this one is called Vyleesi, and it's the generic is called bremelanotide. And bremelanotide is an injectable medicine that is similar to Viagra, where it is more on demand, but it's more similar to Addie in the sense that it works on the central nervous system. So the mechanism is similar to Addie, but the quick onset is more similar to Viagra.
So this Vyleesi, is that the generic? That's the term.
That's the brand name.
That's the brand name. So if Addie and then Vyleesi is the injection.
Good. Yeah.
Is that something you're interested in getting busy one night, and so you sneak off to the bathroom and poop a little injection before everything gets going?
Yep.
Is that how we're using that?
100%. So it works in about 45 minutes.
Okay.
It can last a decent number of hours, though. I mean, I've even had some patients tell me it works for a full day afterwards. So I'll sometimes tell patients if they don't know how they're going to respond to it, it's the first time they've used it, to maybe dose it at bedtime, sleep it off, the next morning, wake up and see how they feel. Okay. But in general, yes, most patients will use it at the time that they want to be sexually active.
Okay, so it is kind of the lady Viagra.
Somewhat, yeah.
Doesn't exactly work the same, but sort of. And so what are the big differences?
You have a little twinkle in your eye.
Do I? Oh gosh, getting a little sassy over here. Very interested in these medications. Why would you prefer? Well, obviously you'd prefer one over the other for the moment of activation, because the Addie takes a longer time to work. But are there any different? What's the side effect profile for the Vyleesi for the injection?
Right. And yes, absolutely. So I oftentimes, if patients really don't have a strong preference on onset, then I'll just lay it out there and just kind of say, what kind of suits your fancy. So the biggest side effect of Vyleesi is nausea, and it tends to be really mild for most patients that do experience nausea. What's interesting is that if it does occur, it tends to only be with that first injection, and for some reason, it tends to not really happen with the subsequent injections.
So it just goes away.
For whatever reason.
Okay.
We don't really know why. I suppose if somebody uses an injection and then waits a long period of time between the other injections, it could happen again if they're prone to the nausea, but it did occur in about 40% of individuals that used the injection. So for individuals that are really prone to nausea, or they have IBS or like a lot of GI issues, I might be a little bit more hesitant to start with that, and I might maybe gravitate more towards Addy. However, I do have some patients that have a history of GI issues and they do fine with it. So I just kind of leave it up to them, or if they, ask my opinion, then I'll kind of guide them on what I think. And then I have some patients where, privacy is a big concern for them. So maybe the pill might be better for them because they don't want to have to plan ahead. I have other patients where they don't want to have to take something every single day. And so the injection is much better for them. So it really just comes down to preference.
Okay. Here's another question I'm dying to ask. So let's say you start taking the Addy or either you're doing the injections as needed and on demand. Can they poop out? Can your reaction to them fall off at a period of time? Or is it something we keep using this as long as we need it?
Mm-hmm. Yeah. Both of these medications are designed to be long-term
They
products.
are designed for long-term use. Mm-hmm. Okay. So Addy is not something you can only use. It's only going to get you working for a year.
Correct.
Okay.
Yeah, they're both designed to be long-term. And so I tell patients at any point, if you decide that you want to try and stop or wean off, totally fine. You let me know. I definitely have patients that will stop either product or both products, and they do great. It's almost like a reset button for them. And then I have patients that stop them and they're like, holy crap. It's like a light switch went right back off. And
I'm back to zero again.
Exactly.
I'm back to where I started. That was going to be another question. Taking these medications or not treating the HSDD at all, does it ever improve on its own? Or is it something that once you feel that you can reasonably diagnose this issue, it's not going to turn around for you? You're going to need some help.
Yeah. Absolutely. It can definitely spontaneously resolve.
It can.
Yeah.
Okay.
That being said, though, there's no reason to suffer, and I say suffer, not even jokingly, because it absolutely can be incredibly distressing, not just to the individual, but if they're partnered, it can have a monumental effect on the relationship, on the family dynamic, on work. Lots of studies show how this can impact every kind of subset of the individual's life. So this is a really big aspect to a woman's life. And I think it's important to be open and honest. And this is a huge part of being a human, and we should not be embarrassed to talk about this.
But we are.
Darn it.
We're completely embarrassed to talk about it, especially women, because we feel like I don't know what we feel like we are. We feel like we're not allowed to have these feelings. Somehow they're dirty. Somehow they're inappropriate. And then we certainly aren't allowed to talk about them.
In the South.
In the South, especially, which is where I grew up. We are in Nashville. I've certainly lived other places in my life where these things it was much more acceptable to talk about them. But definitely in the South, I think we're still living under some rigors of not wanting to talk about that. So I think it's amazing that you've been able to talk with us about these two drugs today. Even more amazing is that they exist, and I'm pretty certain if I polled a pool of my girlfriends, not one of them would have heard of either of these medications, and no physician would have ever mentioned these to them. Last question, and this is just for my interest, and I'm sure everyone's, do all physicians know that these exist for women?
No. There is a process of care that was published from the International Society for the Study of Women's Sexual Health. So it's an HSDD process of care. It's open access, and it's a very easy little algorithm that a healthcare provider can follow. I encourage anybody that's interested to either, if you're non-medical, you can go online and pull it for your healthcare provider. If you are in medicine, you can pull it yourself and just kind of read through it. And it goes through the medications and also talks through things like testosterone, which can be used off-label. Again, we don't have any FDA-approved testosterone for women, but there's also a process of care in how to use testosterone off-label for women for HSDD and other factors just for hormone replacement. One little thing I wanted to mention, too, is that with Addyi and Vyleesi, they are only approved for premenopausal women at this moment in the U.S.
For premenopausal women.
Yeah.
Okay, that's a big
It is a big thing. I forgot to mention.
That's okay.
So
premenopause.
We have studies to show that there's efficacy in both pre- and postmenopausal women for both medications, but we don't yet have that approval. And in the U.S., this is another silly little thing, we look at pre- and postmenopausal women as two separate entities almost. And so the FDA essentially requires these pharmaceutical companies to implement studies. They must pick one group or the other, go through the process of gaining approval for one subset or the other, then start the process over to gain approval for the other subset. And so both companies decided to go for premenopausal, gain that designation or that approval, and we haven't yet gain that approval for postmenopausal.
Does that mean that somebody's in process of doing those studies in the postmenopausal women?
They have studies. I don't know where the companies are gaining approval, at least in the U.S. They do have approval in other countries, just not in the U.S. So.
Okay, but it is approved in other countries. Can women, postmenopausal women, still take these drugs?
Absolutely.
Absolutely.
I prescribe both of these medications all the time.
Okay.
Probably equally, to be completely honest, off-label, which is kind of silly to even say that, for women of all ages. And I have great efficacy. And we know, based on the data that we have that's published, that there's reasonable safety and efficacy data for women of all ages.
Okay, so we've heard that. So pre and postmenopausal women, this is for you. This is for me. This is for us. Okay, let's boil this all down into my favorite segment. Just the tip. So today I have learned a couple of things. First, low libido in women is the symptom, and HSDD, Hypoactive Sexual Desire Disorder, is different. It is a diagnosable condition, and there's a difference between the two of those. So I think that's very important for everybody to consider. Just because you're not interested and you'd really rather be watching Netflix than hanging out in the bedroom doesn't necessarily mean you have hypoactive sexual desire disorder, but it doesn't mean you don't. Talk to your doctor and work with your medical professional to see if HSDD is something that is affecting you. How'd I do? Did I get it?
That sounds great.
Okay. All right, Stream Team, thanks so much for sticking with us, and stay tuned because I'll be back solo with Brooke, and we're going to talk even more about women's sexual dysfunction because nobody else is talking about it, but we're going to do it. See you soon. Thank you for listening to this week's episode of Balls Deep. If you'd like to join our Stream Team of listeners, please click the subscribe button on your favorite podcast platform. For more information about our practice, Pizona MD, please visit PizonaMD.com. This podcast is for informational purposes only, and the content is not intended to be a substitute for professional medical advice. The show does not constitute the practice of medicine. No doctor-patient relationship is formed through this podcast or any of the social media channels related to this show. The use of this information is at the user's own risk. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.